right, good morning, everybody. We'll start now, so we end on time. Just for those of you who don't know me, my name is Damien Rose. I'm one of the co-chairs of the Grand Rounds Committee. It is my true pleasure to introduce to you Dr. Nicholas Rosenlicht. Nick came to UCSF from the Robert Wood Johnson Medical School, where he was heavily involved in medical student and resident education. Since arriving at UCSF in 1997, he has been a stalwart clinical educator at the SFVA, having worked in outpatient, CL, psychiatry, having founded and ran the mood disorders clinic there. This is actually where I met him in the early aughts, where I found him to be a skilled and patient supervisor to then quite raw junior me. One quick memory is how calmly, and one might say sweetly but firmly, he reminded me that, Damien, 4 milligrams of Ativan might be too high a dose for a sleep aid. He was right. With over 40 years of academic experience, Nick has participated in research on sleep, depression, mania, social phobia, and PTSD, and was an early investigator of RTMS. But he's here to speak to us today about a topic that is probably close to many of our hearts. In a time where I feel like the knee-jerk response to tensions in patient care seems to be, quote, medicine is a business, I think we need to keep asking what type of business we want it to be. Nick aims just to do that. He has recently published a book on this very subject, hopefully some of which he will summarize for us today. His talk is titled The Business of Mental Health and Its Abandonment of the Mentally Ill. Please join me in welcoming Dr. Nicholas Rosenlicht.
Thanks, Damien. Well, it's nice to be back here. You know, after 20 or 25 years in the department, this is like the third time I've been in this building. I really appreciate the invitation. And this is going to be summarizing a lot of what I've gleaned from 40 years as a psychiatrist. And I doubt there's many things I'm going to say here that are a surprise, but I'm going to try to put it together in what I think makes sense about how did we end up where we are and how to get out of here. I started off in internal medicine internship and decided I really wanted to go into psychiatry because I felt like I was making the most difference in people's lives. And I felt that over the next few decades, it was going to be the area of medicine to change more than any other. We had new medications. We had advancements in therapy from the very rigid doctrinaire Freudian analysis to self-psychology and object relations. It seems like things were blossoming, and I wanted to be part of that change. I have to say that the last 40 years have been a real disappointment. I've been in practice, actually, as well as my work here. I've worked in community mental health centers. I ran community mental health center out at Robert Wood Johnson. And I think we're doing a worse job of treating the mentally ill than we did 40 years ago. And I'm going to go through this, and it's sad. And I think there's some very concrete reasons for it that we need to really look at very, very hard. I did, as Damien mentioned, I've written a number of op-eds, and I finally just sat down a pandemic project, and I did a book called My Brother's Keeper. And I'm not a particularly religious person, but it refers to the King James Bible, where when the Lord confronted Cain about Abel's death, whom he had murdered, he said, am I my brother's keeper? And that's sort of how it's been going, where the mentally ill are not our problem. It's not us, they're them, they're othered. And, since I've been working on this book, this is happening throughout medicine. The things that work to exclude the mentally ill from care are now being done on all of us. And I just listened to the news on the way over. I think we're all kind of screwed about whether we are viewed as a community to take care of each other or it's every man for themselves. Anyway, to start out, you'll hear these things about healthcare and about mental health care, that our system is broken, that mental illness is not real, the whole myth of mental illness. Besides, mental illness isn't treatable. These are crocs and there's not much we can do anyway. Mental illness, the treatment just costs too much. We just can't afford it. I'm sorry, but we're not going to waste our money on this. And there's miracle cures around the corner, TMS, ketamine, these new things that are going to make it all okay. So we'll just wait till that comes around, but no need for us to worry today as soon as these cures arrive. And mental illness does not affect me. It's someone else's problem. And I'm here, and I think I'm preaching to the choir. These are all patently false. They make no sense at all. And I think, well, it's a little bit like I was mentioning what's going on with Martin Niemöller comment about during Nazism, where first they came for the socialists, then they came for the trade union leaders, then they came for the Jews. And that is happening today for people with illness, which is all of us. That it's a business opportunity and people are systematically being excluded from care. And I think we do have an opportunity that is spread so wide that it's time for us to really relook at how we look at the care of the human body, including the mind. So I hope the time is right. So how are we doing in the US? This is our healthcare in general. For the last 8 years in a row, the Commonwealth Club has ranked the US healthcare the worst of 11 developed nations in terms of equity, quality of care, healthy lives, the worst among the developed nations. Yet, and then, for example, Bloomberg Business News ranked 56 countries on their quality of their healthcare. We ranked 54th out of 56. We tied with Azerbaijan. We did beat Bulgaria, widely viewed as the most corrupt nation in the European Union. Yeah, way to go, US. Life expectancy in this country compared to most other developed nations is 3 to 5 years less. How is this possible? A child born today has a shorter life expectancy than its parent. How is that possible with all this technology and money we're putting? And we are putting in money. We spend almost twice as much as other developed nations on our healthcare. We're getting close to 20% of our GDP spent on healthcare, yet we're getting worse results. What is so different about this country and others? It's not that we lack expertise, dedicated, hardworking clinicians, devices, technology, medications. No, there's systemic things that are holding us back. A thing that I feel was very important that set on us on this backward path was a well-meaning thing. This is the HMO Act of 1973. It was brought forward by Teddy Kennedy, signed into law by Richard Nixon. And its idea was to make medicine more of a business, make it responsible for market constraints, that we could manage it more, that it could be managed by other things that would watch where our dollars are spent. And it had some insidious effects. Yes, it was well-meaning. People were very worried. At that point in time in 1973, our healthcare cost us 7.3% of the gross domestic product. It's now gone tripled that almost 20%. So we passed the HMO Act, and that's what's happened with our healthcare dollars as a percent of the GDP. Compare this with Canada. A couple of years earlier, they passed their universal health plan. And as you can see, they were actually spending slightly more than us back in the early 70s. They now are a little more than half of what we spend, and they get better results. The other thing this did was it really legitimized the feeling that healthcare is a business, not a kindness or a mission. That what drives it is dollars, not health. It really changed our orientation. For almost a century, we've had what are called CPOM, corporate practice of medicine laws, and I will get to those, which basically forbid businesses from making decisions about healthcare. And the Park Doctrine laws, which would hold businesses responsible for the harm they do to people. These were torpedoed by the HMO Act. It became legitimate that business interests would guide healthcare, not health guiding healthcare. So is our healthcare system broken? That really depends on who you ask. Some people find it's working very, very well. You know, one of the bad boys, United Health, their revenue last year was almost $400 billion. That means that every man, woman, and child in the United States contributed $1,200 to their corporate coffers. That is massive. Other things, the average healthcare CEO currently earns over $13 million. You know, so much for the well-meaning people who are running healthcare. But this affects all of us, this model. In 2022, the shareholders of Pfizer, Moderna, J&J, these are just investors, regular people. They voted not to share vaccine technology because they wanted to protect their investment in dollars, thereby not allowing the cheap production of vaccines in this country and elsewhere. They were basically sentencing people to death so they could maintain their profits. This is what the system does to regular people. We're all complicit. Who doesn't have a 401k or their funds in a mutual fund, which invest in these companies who are hiding healthcare technology so they can protect their profits? This last thing there, healthcare companies paid $170 billion in shareholder payouts in 2022. Well, that's the way business is worth. But if you're paying for your healthcare or you're paying your insurance company, why do you want that money you're paying to go into an investor's pockets? It should be going into healthcare. Why do we decide that it's okay to siphon off dollars that are meant for health for other people's profits? Sure, people can make a profit, but that is, for every dollar profit means a dollar that's not spent on saving or protecting human lives. Why did this model persist? And we are the only developed country that allows this. And you need a system to manage this. This is looking at physicians versus administrators in healthcare. We have now 40 times the number of, quote, healthcare workers as we did 50 years ago. We now have 16 healthcare workers for every one physician. Some of them are other clinicians, nurses, and otherwise, but 10 of these 16, 5/8, do not deliver health. They manage the money, which is largely protecting against providing care. 95% of the growth in healthcare has been in the business side, not in the delivery of care. As a matter of fact, these people are generally blocking care so they can maintain dollars. That's their job. Here's a simple example of this you may have experienced. It's estimated that Americans spend 500 million hours on the phone with their insurers a year. That's like an hour and a half on average for every person in the United States. The average visit with a primary care doc now is 7 minutes face-to-face. And it's not face-to-face, it's face-to-face, them typing there on the computer, that's talking to the side of their head. We spend more time arguing the business side of medicine than getting care. Looking at like the massive growth of electronic health record, looking at the Epic system, which is used here and in other countries, in the United States, Epic notes are 4 times as long as in other developed countries. And that's not because we're delivering better care, we're delivering worse care. It's because what they're doing is they're providing a financial note rather than a care note, 4 times as long. Most primary care docs now spend between an hour and 2 hours in the evening doing these notes rather than caring for patients. Healthcare is the largest lobbying industry in this country with over 3,000 registered lobbyists. That's more than almost 10 for every person in Congress. It's also the largest contributor to federal campaigns of our legislators. Again, I don't really think that when we're paying our insurance money or we're paying for healthcare, why it's ending up in the pocket of a legislator. This is not efficiency. Results, 41% of adults in this country have healthcare debt. From 2009 to 2020, medical debt and collections exceeded all other forms of debt for Americans. 2/3 of Americans who declare bankruptcy cite medical reasons as a major reason for their downfall. And you want to remember, these aren't people outside the system. Most of these people have insurance. They're doing it the right way. Things are just worse for mental health, but I think what we'll see is that what's been foisted off on mental health has become the norm for the rest of health. It's worked so well to increase co-pays, higher deductibles we have in mental health, lower plan maximums, limited treatment coverage, restrictions on the coverage, stricter prior authorizations and authorizations for continued care, restriction on drugs and the type of treatment. This is now becoming throughout medicine. It was piloted in mental health. And this is despite parity laws. Yet these companies find it cheaper to have these discriminatory policies than to pay the fines. Mental health care has been squeezed. Clinicians are paid less. The payment out to psychiatrists compared to primary care docs for the same procedures is generally 25% less. Yet we spend far more time with our patients. And then the use of lesser reimbursed clinicians. If you have a problem with your liver and your lung or whatever, another organ, you're not going to go to a master's level therapist. You're going to be seeing, at least under supervision of a doctor. The average wage in industry to a master's level therapist, not ones in private practice, is different in the Bay Area, is $24. These are federal statistics. This is because the insurers want to pay as little as possible to mental health. And I'll go into some of the reasons that occurred. Applications to psychiatry have gone way up, but still 60% of all counties in the United States do not have a single psychiatrist. That's 80% of all non-metropolitan counties. A stat from a few years ago is that insurance companies allocated 4.4% of their payouts for care to mental health and substance abuse. 4.4% of their payouts. It's really hard to get care under insurance or adequate care. Psychiatrist visits are paid completely out of pocket 15 times more often than to a primary care doc. It's basically the rich can get care, but otherwise you're screwed. Then the reality is that like 80% of antidepressant prescriptions are written by primary care personnel rather than psychiatrists. Yet about 5% of their training of generalists is in psychiatric illness, yet they do the lion's share of prescribing. How is mental illness real and does it cause problems? I know I'm probably preaching to the choir here, but this one stands out. During the pandemic, which overturned our country, government payouts for shutdowns, et cetera, exceeded the cost of the Great Depression. During the pandemic years, 2020 to 2023, we lost 1.17 million Americans to COVID. 1.17 million Americans. During the same 4 years, we lost 1.31 million Americans to suicide, alcohol use, and overdose, more than to COVID. Yet we're worrying about what we're spending on mental health, and it's severely restricted. As I don't need to tell you, serious mental illness is associated with a 10 to 20 year decrement in lifespan, but hey, what the heck? Reality of things. For all our worry about physical illness, mental illness causes more suffering and disability than virtually all physical ailments. A large of this is for its chronicity and lack of available care. And here's where public opinion often diverges from the reality. These are 2023 surveys. I think this Kaiser Family Foundation. 9 out of 10 adults said that there was a mental health crisis in the United States today. And mental health was the single greatest health concern for Americans. But does this translate into money or policy change or getting people off the streets? No. And I think, you know, I'm speaking to the choir here, there's such an aversion to dealing with mentally ill. It's ugly. And then there's the courtesy stigma that psychiatrists get that I'll go into a little bit more. There's such worry about violent crime now. We've got, oh God, the news this morning wanting to send federal troops in Los Angeles, Chicago, and other generally democratic cities. For all our worry about violent crime, Americans are 2 times more likely to die at their own hands than at the hands of another. 5 times more likely to die of an overdose. Yet we're going to send troops in to protect Americans. 4 out of 5 pregnancy-related deaths in this country are preventable, and the overwhelmingly largest cause is not preeclampsia, gestational diabetes, and these things, suicide and overdose. Yet we don't deal with this. So how's it going? For example, I'm sure, Matt, you know, this is the second most common cause of death in 10 to 24-year-olds. In this country is suicide, behind only accidents. In the year before last, half of people, the adult with a mental health condition, received any treatment for it, and a quarter with a substance use disorder received any treatment. It's just not part of our culture or our care. There was a Kaiser Family Foundation poll in 2023 and they found that this is a quote that 2/3 of Americans, they themselves or a family member experienced addiction to alcohol or drugs, homelessness due to an addiction, or an overdose resulting in an emergency room visit, hospitalization, or death. And I know I'm speaking to the choir, but I've been giving this talk a lot of places. There is no one who does not know someone, a family member, a friend, or a friend's family, whose life has not been eviscerated by mental illness or substance use. Yet, hey, we just look the other way. What the heck? What can you do? I mean, you get this at parties. I mean, people come up to me and then they hear I'm a psychiatrist. I get all the jokes and what about Bob and Hannibal Lecter? But I get calls the next day, or they corner me by the coat room. Hey, you know, my kid's in real trouble. But they hide it and they talk about it in dark corners. I won't spend a lot of time on this, the history. You know, we all have heard about these horrible asylums. It's important to note that, you know, psychiatry didn't form the insane asylums. The insane asylums recruited psychiatrists, became the specialty to manage the asylum. This is a quote I didn't even know about this, but I love this. In 1844, the first national medical society in this country was the Association of Medical Superintendents of American Institutions for the Insane. This was the first medical society in the United States. In 1892, it changed its name to the American Medical Psychological Association. In 1921, it changed its name to the American Psychiatric Association. There was no such thing as psychiatry back then. The asylums were formed by dedicated do-gooders like Dorothea Dix, because of the horrors of mental illness. They saw a lot of PTSD from, you know, the Civil War and all this, and it was a really well-meaning movement. It, however, not surprising, was inadequately funded. By the middle of last century, 1 in 2 people in a hospital bed in this country were in an asylum. Half of hospital beds in this country were for the mentally ill, and they were overcrowded. Initially, apparently, in the 1800s, these places worked pretty well and had high discharge rates, but they became overcrowded hellholes. And there were scandals around it. Life magazine did an expose, I think in 1948, just showing pictures of these naked, feces-encrusted people at these overcrowded asylums. There's movies like The Snake Pit. which is actually sort of stunning. Olivia de Havilland played this woman for unknown reasons, ends up in an asylum, and is saved by a well-meaning analyst. There's things like One Flew Over the Cuckoo's Nest, which was a little later, but as Ken Kesey himself, who wrote it, said, well, it's the reality, even if it didn't really happen. I mean, there's such prejudice against people with mental illness, or the courtesy stigma that happens to people who would actually lower themselves to care for these people. There was an interesting book from the late 40s called The Shame of the States by Albert Deutsch, an interesting character, very smart advocate for the mentally ill, but also had been a consumer himself. And he went into these asylums and he interviewed people. And they're saying, no, stop. These people did not want all these patients. They couldn't handle. We're overloaded. Send us nurses, send us doctors, send us facilities, please. He brings out an interesting statistic. By around 1950, the average we spent on a person in an asylum was $1.25. That's $16 in today's dollars for the room, board, medication, therapy, physical therapy. Their entire care was $16 a day. You know, any wonder that these were hellholes. Anyway, there was also, heard about a lot of anti-psychiatry movements in the 60s. R.D. Laing, Thomas Szasz, and the whole myth of mental illness. Irving Goffman, who had a lot of good ideas, but his whole idea that the idea of institutionalizing people, which really wasn't a great thing. These people railed against the myth of mental illness. Of course, R.D. Laing stopped this pretty much after his own daughter came down with schizophrenia. Thomas Szasz ended up taking his own life. And Irving Goffman, too, stopped being such an anti-psychiatry advocate after his wife committed suicide. There was also, I don't know if you've read this, something called, it was Rosenlicht's Being Sane in Insane Places. It was a very, very influential article that appeared in Science magazine in 1973, where he and some colleagues from Stanford would voice nonsense words like clunk or funk and not even offer history, ended up being hospitalized psychiatrically, kept there long after supposedly other patients knew they were faking. And the main thing is that the public ate this up, this nonsense of psychiatry, mental illness. These are fakers and charlatans. And it had been cited more than 7,000 times last time I checked. There's a British publication that put out a study about this. Susanna Callahan published a book a couple of years ago called The Great Pretender. Colleagues of Rosenlicht characterized him as a, quote, bullshitter. Much of his statistics were clearly made up. He himself, who claimed he went in and just behaved normally and they kept him in, and as he took notes, they said odd note-taking behavior. Actually, she uncovered some of the notes that showed he would walk around all day holding pots over his head to silence the voices. It was not an honest representation. Nonetheless, the public ate this up. In 1986, also published in Science, was a survey that found that 55% of Americans didn't believe that mental illness was real. Anyway, with the deinstitutionalization, there was John F. Kennedy's National Plan for Mental Health, which is largely, a lot of this, I think, had to do with this. His sister Rosemary, who ended up in an institution, and with a botched lobotomy, he wanted to promote quality outpatient care, and he set up this system of community mental health centers across the country. This was his last bill signed in an act he signed before his assassination 2 weeks later. You know what happened then? He was assassinated, Johnson took over, we had the Vietnam War, and the community mental health centers were never adequately funded, and they were generally funded by lesser trained individuals who were not quite so good with handling the major mental illness. They did family therapy and other things like that, but the severely mentally ill were basically abandoned. They went from state institutions to homelessness and prison. Those who could afford psychiatry went to offices, but much of this was self-paid. Here's an interesting graph I think you'll find. In around 1960, we had over 500,000 people in institutions. It's now less than 50,000. We have 1/25th the number of public psychiatry beds as we did back then. So where do these people go? Streets and prison and jails. They basically moved over to seriously mentally ill, or in revolving doors in and out of local jails. I mean, I've had so many patients, especially at the VA, who at least they could get some care. You know, when they're hungry and scared or their voices get too much, they go break a window, and it's a way, you know, it's not great, but at least they get housed and can get out of the storm and get fed. And people do what they need to do. Today, someone with serious mental illness, if you look at the numbers, is 10 times more likely to be in a prison or a jail than in a hospital. They're most likely, of course, to be on the streets. There's this artificial divide between mental and physical illness, that mental illnesses are chronic. We don't have cures, but so are most physical illnesses, or many that we deal with. Arthritis, diabetes, multiple sclerosis, all these illnesses. Chronic illnesses, mental and physical, are common. They're often lack precise diagnostic boundaries. They're complex entities. They may have multiple causes or exacerbators. They're disabling and life-shortening, and they're treatable but not curable. But why is it with mental illness? Well, you've had, you know, your 12 sessions. I mean, you're not going to hear that with somebody with cancer or diabetes. I'm sorry, you're just not responding to the insulin well enough. You're still needing it. We're going to have to catch you up. But that's okay in mental illness. Mental illnesses are just as treatable, but not curable as these other chronic illnesses. In our system, basically, the poor get sicker and the sick get poorer. And it's the economic model. It's only fair. This is the deal. You pay for care. You can't pay for care. I'm sorry it's going badly for you, but this is the deal. This, of course, exacerbates other inequities in our society. For example, African Americans make up 13% of the population. They're 40% of the homeless and 50% of the incarcerated. There are a lot of reasons for that, but mental illness is part of it. And you contrast it with treaters. This is stats from about 10 years ago, but 88% of psychologists and 95% of MFTs are white, identify as white. 2.6% and 1% identify as African Americans. Psychiatry is a little more even, but that's because of the paucity of American psychiatrists. We've had to recruit people from other countries so they make our numbers look better. So, with this medical technological model, how have our treatments improved? This is compared to a generation ago, and when I started out, far and away, the best treatment for bipolar disorder, no question, is lithium. It was first used in 1948. Schizophrenia, far and away, the best treatment we have is clozapine. It was developed in 1956. I know they're bad boy now, but far and away, the greatest effect size and immediate treatment for panic and anxiety are the benzodiazepines. And yes, they've been abused. But I'll tell you, when you actually have a therapeutic relationship with someone and use them in a time-limited manner as you institute other treatments, they work and people get off them. The problem is in the way we use them, where we hand somebody a 6-month supply and say, figure it out. It doesn't work so well. The tricyclics, which were around since 1957, are as effective as any other of the medication we have today. This is 75 years ago. These new psychotherapies, Aaron Beck, published about CBT in the 1960s. And if you've ever read Marcus Aurelius's Meditations, the Emperor's Handbook. It's pure CBT, and it's from around 40 AD. It is 2,000 years old. These are not new treatments we're using. Our most successful treatments today are a generation or millennia old. And when you look at things from a business point of view, this is a quote I love from Goldman Sachs business report. It was cautioning pharmaceutical industry not to make any cures because this would cut into their long-term prospects, like when they blew it and actually came up with a cure for hepatitis C. Is it too costly to treat mental illness? Major US cities today, 1/5 of law enforcement time is spent on managing the mentally ill. We spend $80 billion a year on incarceration, around half of which this is for the people with mental illness, at about $120,000 per year. Do you know what kind of care you could get for $120,000 a year? Good quality, effective outpatient treatment. This is just a little odd statistic I saw. In 2021 alone, the LA Fire Department reported 9,000 homeless-related fires. You know what it costs to send a fire crew and a fire engine out? And what are these fires? These are people trying to cook their dinner largely, or confused. Why do we let this happen? Well, is it too costly to treat mental illness? There's multiple studies showing that, well, first of all, people with mental illness and those with substance use problems are high utilizers of the physical care system. They have physical care, they don't take care of themselves, and they are tremendous burdens on our society in terms of physical health needs. There's a 2021 study in New Zealand, and they found that by enhancing mental health treatment, they would lowered overall health costs. And a study out just this year in JAMA looked at a company that enhanced its mental health benefits and found that for every $100 spent on mental health treatment, you saved $190 in overall healthcare costs. The cost of untreated mental illness in this country is estimated at around $300 billion. So why do we relegate the treatment of the mind to second-class status? And I think this is really controversial, but I don't think framing mental health treatment as a business for clients is doing us a service. I mean, using euphemisms may seem kind, but it also then entrenches and further stigmatizes people who are mentally ill and might be called patients. Plus, it provides a rationalization to disqualify them from care or insurance reimbursement. I don't, whatever people want to be called. But when we view it as a business client, it ends up making reimbursement and parity much, much harder. It was a really interesting Kaiser study over 25 years, and they found that 60 to 90% of primary care visits were prompted by psychological and stress reasons. Yeah, people have physical illnesses. Everybody ends up with physical illnesses, but that's not what is bringing people into their doctors. And it was a lack of mental health care that drove them into these visits. There was actually a Bureau of Labor Statistics in the Department of Labor last year found that insurers routinely treat mental health care differently. There was a fine a couple of years ago against United Healthcare. They got fined $15 million for their discriminatory care of the mentally ill and substance use. But if you look at it, their revenue and that fine, it would be like giving a $4 fine to somebody who earns $100,000 a year. For them, it's just a simple business decision. It's cheaper to ignore these rules, and if you get fined, tough luck. It works better to do it that way. And there's the whole thing of calling clients. It's a useful evasion, but it entrenches the shame at being a psychiatric patient. I mean, the LGBTQ community has made great strides by embracing formally disparaging terms like queer or gay. I mean, be honest about what's going on. Walking around in shame and hiding behind another term is not useful. I don't want to slam someone, and I call them whatever they want. Found at the VA, it was useful to call people sir or madam in honor of their service to the country. But your mindset about this person is here for healthcare. They're not here for a product. It allows us to feel safe. Mental illness is a choice, somebody who's buying or wanting a product. And a client is passive. A service or product is provided to them. A patient is somebody who is in a collaboration for care. In almost any healthcare setting, the patient does the majority of the work, even in surgery. Somebody may cut on you, but you're going to have months of healing that the patient has to do. And it provides an out for insurers. It's the monetization of a relationship whereas a patient is a relationship that's defined by empathy and collaboration, generally absent in a financial transaction. In our country, 1.3% of philanthropic giving goes to mental health. That's how much our society prioritizes it. Yet, in JAMA, there was a survey showed that 73% of the population supported policies to expand access to community mental health services. And these numbers were equal among Democrats and Republicans. I don't like stepping over bodies when I shop or slipping in feces. Why do we ignore this and figure, oh, it's cruel to hospitalize somebody? I mean, if somebody is caught treating their dog the way we allow it, treatment of our mentally ill, they'd be cited. So what can we do about this? We need to get serious. I mean, it's like, I think we've been taking like a knife to a pistol duel. Physicians and healthcare workers are not supposed to be political. I think that time is over. Healthcare is a basic human need. We don't expect fire departments to make money. Why is it we're expecting healthcare to make money? It's time we change the dialogue. All people with an illness are patients and deserve care. Stop seeing healthcare as a profit opportunity. We are the only developed nation that does not have a plan to take care of everyone, and it's a government moderated. Yeah, the government is wasteful. I've worked for the VA for years, but it's a lot better than companies making $400 billion in profit that goes to rich shareholders and forcing us, if we want to make money, we're going to be in a mutual fund that is funding companies which are extracting money away from healthcare. Quit acting as if we aren't affected. Who doesn't know somebody who their life is not devastated by mental illness? This is not rare. This is not the other. Cut it out. Equal rights for all organs. Segregating systems by the organ is not making sense, and integrating care, I think, needs to be done. And really working towards some sort of single payer system where we can, through voting and what we want, manage healthcare, not to a profit. We need to let legislators know. And why are they taking healthcare dollars? Why is money that is meant to, that we pay into insurance, that's meant to take care of people like us, why is it ending up in legislators' pockets? Fight the moral injury and stand up. Like psychiatry, people make fun of me, but they call me the next day. Just ask them, oh, you don't know anyone with mental illness? Tell me about that. We need to enforce these laws that already exist and strengthen them, the corporate practice of medicine laws. There are laws that forbid corporations from making healthcare decisions. Yet when you won't pay the exorbitant prices that we have to pay for healthcare now, and telling somebody, oh, you can pay for it yourself, as people do with psychiatrists, that is against the law. Why are we allowing this to happen? And I think this means we need to get involved. There's like, I recommend the Physicians for National Healthcare Plan, which is organizing for getting us some sort of single payer plan. And there's a student version, SNAP, the Students for National Health Plan. There are organizations like Inseparable or No Health Without Mental Health, which really argue against this weird segregation of mental and physical health. NAMI, they're working hard now. They used to be kind of, keep their heads down and take care of poor family members. They're a lot more politically active now, and I've been speaking for them. I really recommend, we need people on our side. National Single Payer, other ones. It's time to get politically active. There are other models. I mean, in Oregon, in Eugene, there's Cahoots, which is they're helping out on the streets, which active, aggressive mental health care on the streets. The Trieste model, where there's peer support, peer counseling, drop-in centers, brief hospitalizations, and that part of maintaining somebody's mental health, and I hate doing this, mental health, we don't talk about somebody having a cardiac health emergency. People with mental illness, you have peer support, you have a place to live, you're fed, you have a place to go during the day, a workshop, but you're part of society. Everybody contribute somewhat. In my city, there was for years a guy who stood on the street corner during commute hours just waving. People loved him. He had a role. He didn't have to sleep in his own shit in front of the supermarket. Why are we excluding these people from our society? Anyway, I know I'm kind of talking to the choir, but anyway, thanks for your patience. And I guess let's I'll open it up to questions. Yeah.
Thank you so much for this amazing presentation. I wish I could say that I hadn't heard some of this stuff before, but I think this is an alarm that's been ringing for some time now. I wanted to ask you what your thoughts were on business incentives and how that's come into play. I'm a relatively young faculty here, and so it's, how do we strike the balance between, coming up with my RVUs while also taking the time to actually make effective change in a system that pushes us away from the change?
Well, I think it does have to be divorced from the economic incentive. We can't give unlimited care to everyone, but why is it based on basically financial units? I mean, it should be care units and what this person needs. When you have companies for profit, and actually these not for profit companies, that just means they don't have shareholders. I mean, Kaiser, which is probably best the worst in general, their mental health care is just so inadequate. Even these so-called nonprofits like Sutter are venal in their management of their money and how they manage mental health. It can't be tied to dollars. I think it needs to be tied to policy. And we do need to really look at what works, and there do need to be some hard decisions. But why is it about putting down what you're going to charge for them rather than what they need? There needs to be, I think this whole idea of we have units of care that are financially determined really just doesn't work.
Thank you. I agree with you.
I mean, outcomes for major mental illness in India are better than for us with schizophrenia. And it's because people are kept in the community. They're not viewed as, something evil and bad or something that you can catch. I mean, advocating for the mentally ill. And also that, when people are behaving abhorrently, they do need to be reined in. They're doing it because they're sick, not because they're mean or they're a criminal. It's care they need, not punishment or ignoring. I mean, we've all had patients, they're railing against treatment, but they do so much better and are happy when they're no longer railing.
I know the ACA was trying to do some of that work, but we'll see where that policy stands.
Yeah.
Thank you again.
Well, right now, listening to the news coming this morning, I think we're basically all being treated like we're mentally ill. I mean, police and troops into cities, I mean, any sort of behavior that is against the paradigm of what our government wants is going to be punished, which is what we've been doing to the mentally ill. So there is, I think, an opportunity to turn around the way we treat everyone else.
Thank you for a great talk. I think you've laid out the issues, and I was wondering if you could talk a little bit about the solutions, which daunting, right? Like it's huge systems. Do you have examples of how systems change at a large scale? I see organizations, do they have ideas that are sort of like most striking as going in the right direction as far as you can tell? What's the timeline of change? Any thoughts on that would be really greatly appreciated.
Well, yeah, we have models that work, or at least work a lot better than ours. Look at other developed nations. We are the only nation that doesn't have a national health plan. Their outcomes are far better than us, and they spend half the amount of money. In terms of specifically mental health treatment, the Trieste model, and it's been done in some cities, the CAHOOTS, which is assertive outpatient care, giving people what they need: food, clothing, and shelter. Oh, you shouldn't give that person shelter. Yes, you should. Keeping them off the streets and getting them healthy saves money in the long run, and it makes our world a kinder place. I think, again, there is an opportunity now that we're all getting screwed to band together with other areas of medicine. They're now in such horrible shape, especially primary care, that it's time that, a majority of physicians and actually people, depending how you ask the question, do want national health, because people are so scared of falling off the wagon and being left behind and homeless. And, if you're not mentally ill when you become homeless, try spending a few weeks on the street. You need to keep awake at night, and the drugs to use to stay awake so you're not beaten, pissed on, or robbed. I mean, is this how we treat members of our society who are suffering? I mean, it's so embarrassing. And I think we're all feeling shamed by it. Get people into the tent, but they do have to behave certain ways to get into the tent. Crime needs to be, treated. But if somebody really can't tell right from wrong, or they're responding to voices, I don't think putting them in jail is really going to help, where they can be raped and beaten. I mean, how did we allow this to happen? It's just a shame. So we have systems to work. Probably the best in my mind is, it's under battle by the right wing, but Medicare. Since I've been practicing, I actually take Medicare. Most psychiatrists don't. And it does pay less, but it's actually been pretty easy, especially, for the elderly I take. It's really seamless. It needs to pay more. And I think if we start equating mental and physical illness, it can pay more. But I think expanding Medicare is a way, and let rich people keep their private insurance, and they can pay what they want. As we get more and more poor people onto it, and get more psychiatrists treating and psychologists, I think we can make a shift towards what other countries are currently doing better than us. I mean, in Italy and in England, I mean, the right wing has been just gutting their health system, but they're still way ahead of us. And again, they're paying half of what we do, and they're doing a much better job. We have models that work, and I think it's by national health care. And we do have a model that's worked pretty well until recently, and now with the whole Medicare Advantage, which is now imploding, true Medicare actually has worked pretty well. It just needs to be I think once it becomes universal, it'll take care of a lot of the problems. Problem solved? No, I really implore you guys to get involved with things like PNHP, ANAMI, and from ground up. And, don't, put your head down at parties and talk about clients, talk about patients. And really, I mean, we have to be maintain confidence, but the stories we have, and I had really hard time, and I had editors help me in the book about using patient examples, and I disguise them and I combine them, but they are moving. And, we need to be respectful of people's, confidence and privacy, but the shame around telling these stories has to stop, because it's a human experience, and it's a common human experience. Come out of our closet. Anyway, thank you very, very much.